The goal of this presentation is to explain the diagnostic value of musculoskeletal ultrasound and its influencing factors. If you perform a clinical test, like a clinical examination test or musculoskeletal ultrasound, you're interested to find out which patients actually have the disorder and which patients don't have the disorder. But with every test, some patients will test falsely positive or falsely negative. Therefore, it's interesting to know the sensitivity and specificity of a certain test. Sensitivity of a diagnostic test indicates the test's ability to detect those patients who actually have the disorder, as indicated by the reference standard. Specificity of a diagnostic test simply indicates the test's ability to detect those patients who do not have the disorder, as indicated by the reference standard. In this table, you can see the musculoskeletal ultrasound values of sensitivity and specificity. Musculoskeletal ultrasound generally has a high diagnostic value, equal to that of MRI. Because it's important to understand the diagnostic value of ultrasound, we'll have a closer look at the statistics in a few minutes. After that, we'll present the influencing factors of clinical practice on the diagnostic value.
So if we've got a diagnostic tool, some kind of test, we want to know what the usefulness of that test will be. So let's take a quick look at a hypothetical example. In terms of the entire population, some people have the disease, others don't. And in terms of the outcome of the test, some people will test positive and some people won't. So when we talk about sensitivity, we mean of all the people that are positive, the people that are circled in green, what proportion of those actually test positive? Those are the people that are circled in red. So it's a fraction, 66 over 70 gives you 0.94. Times it by 100 and you've got 94%. The test will identify 94% of the people that actually have the disease. The next thing we're going to talk about is specificity. We're interested in the population of people who are actually negative. Those are the ones that are encircled in green. And we want to know what proportion of those people test negative, those that are encircled in red. So in this case, those encircled in red are the true negatives. So here we're saying 827 of the 830 will correctly test negative. So 827 over 830 is 0.99, which is 99%. So of people who don't have the disease, 99% of them will be correctly identified by this test. So I'm not going to go through all the calculations again for positive and negative predictive value. Basically, the exact same principle applies. The positive predictive value is the proportion of people who test positive who actually are positive. So the positive predictive value tells me if I go for a test and I test positive, what are the chances that I actually have the disease? Now, there's an important difference between sensitivity and specificity and positive and negative predictive values, and I need to explain this to you. When we look at the sensitivity test, for example, everybody in the green circle actually has the disease. And so the difference between the numerator and the denominator, the numerator being the 66 people and the denominator being the 66 plus 4, so the 70 people, the difference between those two groups is a function of the characteristics of the test itself, and it's not affected at all by the prevalence of the disease because everybody in that group has the disease. In other words, it doesn't matter if it's a common disease or not, because at that point in time, everybody that we're looking at actually has the disease. Now, this is not the case for positive and negative predictive values, because when we're looking at a positive or negative predictive value, the difference between the denominator and the numerator is affected by the prevalence of the disease in the community. And so it's not simply a function of the characteristic of the test itself. Now, this is still a useful test, but you need to remember that when you're comparing one test with another, in terms of the positive and negative predictive value, you need to be looking at the same population group, or at least population groups with the same incidence of disease.
Okay, so now you understand what the definitions of sensitivity and specificity are. You also know that ultrasound in general has a high diagnostic value, but that high value is dependent upon lots of clinically relevant influential factors which are very important for you to know. Let's have a look at them. The anatomy, which you're scanning, can affect the diagnostic accuracy due to a difference in complexity. In this slide, you can see a musculoskeletal ultrasound scan of the lumbar multifidus muscle. The level L4, L5 and S1 can be easily identified. Above these levels, you can see the multifidus muscle, and at the top, the thin, bright white thoracolumbar fascia. Measuring the multifidus muscle thickness is very easy due to its superficial position and the presence of a few clear landmarks. Scanning the temporomandibular joint and its disc kinematics during functional movements can be done, but it is much more complex and requires lots of experience. The temporomandibular joint is a closed joint. The presence of bones prevent a clear view on the soft tissue structures. The disc is small and scanning the disc during movement is challenging. But it's not only the anatomy that can influence the diagnostic accuracy. Pathology can do this as well. Research into the diagnostic accuracy of ultrasound in detecting supraspinatus pathology has shown that some pathologies are harder to rule in and some are harder to rule out. With some pathologies, this is easier. For example, a full thickness tear is very easy to rule in and to rule out. But a supraspinatus partial tear, for example, is harder to rule in and easy to rule out. Meaning, if the tendon looks healthy, then you can assume that it's not a partial tear. But if the tendon does not look healthy, it's harder to specifically diagnose a certain disorder as a partial tear, and a tendinopathy can look quite similar. This slide uses the supraspinatus as an example, but please realise that this also applies to other anatomical structures. The high diagnostic value of musculoskeletal ultrasound is related to a few important criteria. We've already discussed 2 of the 3 patient-dependent criteria, the type of anatomy and pathology. The body composition is also an important factor. For example, the more subcutaneous fat a person has, the poorer the images. Scans made in the geriatric population are also of poorer quality due to the presence of degeneration and connective tissue changes. But if you scan 2 young people with the same good BMI, there might still be differences in image quality based on the different body compositions. The equipment you're using also affects the diagnostic accuracy. Make sure you buy good quality equipment that will serve your long-term musculoskeletal ultrasound goal. If you only wish to use ultrasound for biofeedback purposes, you can buy a different quality than if you're going to use the system for diagnostic or interventional purposes. We always suggest to first do a course in musculoskeletal ultrasound before buying an ultrasound system. Then you will learn much better what ultrasound is about, what kinds of quality there are, if you like it or not, and you know exactly what suits you and your practice the best. If you buy a system, make sure that it has at least the most commonly used functions. Ultrasound manufacturers constantly work on the software to improve the quality. A software update might be smart after a few years. More money buys more diagnostic accuracy, provided that the operator-dependent factors are optimal. These operator-dependent factors are numerous. Firstly, you need good education, which contains blended learning, a mix of hands-on practice and theory. More hands-on practice is always better. This is the reason we use an e-learning platform to make sure that you study the theory at home and you have more hands-on hours when you visit the course. Sonographers need to work in a standardised way and using existing protocols as a base to start scanning a certain joint. You will learn these protocols in the course. Using the protocols makes sure that you scan the absolute basics that is needed for a proper ultrasound assessment. In the next course levels, you will learn extra skills to become a more experienced sonographer. Knowing about artifacts is important. You will learn about these artifacts and their importance in another presentation. A lack of three-dimensional anatomy knowledge is a pitfall in ultrasound. Musculoskeletal ultrasound is looking at three-dimensional anatomy. The entry level of anatomy knowledge is sometimes poor, which leads to people not knowing or understanding what it is they're looking at. Experience has shown that a lot of people have difficulties with not only reproducing and understanding musculoskeletal anatomy, but also with its three-dimensional aspect. This is the reason why we promote doing cadaveric courses to study the three-dimensional aspect of anatomy. In our education, we use cadaveric specimens as much as possible in order to improve your learning. The best sonographers assess the patient with one hand holding and steering the transducer and the other hand on the ultrasound system. Every movement with the scanning hand leads to adjusting and optimizing the system's settings with the other hand. This leads to making quality images and more diagnostic accuracy. You will learn in 2 other presentations about the checklists you'll have to use while scanning. And last but not least, again, make sure you have lots of experience.